Thank you. All right, so one of the things that can lead to burnout are things like medical errors and things like the stress of our situation that we work in. So what I want to do in the next hour or half hour with you guys is to basically talk about medical errors, what they are and what they aren't, and how we can sort of figure out where our own pitfalls are and how not to step into holes too much. So that's what we're going to focus on. It's actually kind of a fun topic. And I'll go sort of into the details of how you can integrate this into your own practice and sort of think about yourself and where you can have some stumbles. So I have no conflicts of interest at all when it comes to medical error, except the fact that I've probably done every single one on the planet. When you've practiced long enough, you've made pretty much every error known to man. So that's my only conflict of interest, is that I've been there, done that. Well, what I want to focus on, really the goals of this half hour we have together, is first of all, what's the scope of it? So what is the scope of medical error? How big is this problem? And what is this idea of safety culture, which hit our sort of sphere of practice about 25 years ago and has led to a lot of the things that we do in patient safety, et cetera, at work. We'll talk about that. We're going to talk about cognitive errors, which are fascinating. How we think is so interesting. And then what I'm going to do, because I'm a big believer in, if I'm going to make you sit through a lecture, I'm going to make sure that at the end of that half hour or whatever amount of time we have together, you have a tool. You have something you can actively go home and use. I'm going to give you that tool to help you minimize your errors at the end of this talk. So last 5 minutes or so, we'll go over that. So the problem for us, sort of the scope of the problem here, is that basically what we're expected to do is be fast, accurate, and really, really nice in a situation where it is absolute chaos, noise, interruption, stress. It's insanity. And a lot of us kind of get off on that, right? A lot of us really like that jazz. It's kind of crazy and fun. And I'll tell you, when you're 26 to 30, it's really great. When you start to hit 50 to 60, it's not so great anymore. You know the toll it takes on you. You know it's kind of ridiculous what we put ourselves through as far as our setting. It doesn't always have to be that crazy. We can hire more people. We just don't. It's nuts. So we are literally setting ourselves up to make mistakes. You could not tee it up better to make mistakes than the situation we work in. You could not do it. It's been known for quite some time now that going into the hospital is hazardous to your health. It's a problem. And this is basically the Swiss cheese model. The idea is, if an error is made, if something bad happens, first of all, if an error is made in patient care that you're involved in, please take a deep breath, take a step back, and realize that you may not be the problem. That the problem may be a systems issue and multiple things. So on the bottom right hand of this slide is like 3 or 4 things that have kind of been background things that just don't work right and not quite right. And there's some problems and issues that all happen to line up perfectly today for the mistake to happen. It's called the Swiss cheese model. All the holes line up and the mistake happens. So if something bad goes wrong wherever you're working or something in your patient interactions, know that often it is not just you, it's often a systems issue. And it's the safety culture concept where you take a step back and say, no, wait. Let's look at the big picture here, because this may be multiple, and usually is, multiple things that happen. We are part of that, but usually it's not just you. It led to this scope of medical error concept. The Institute of Medicine wrote a paper, I think it was in 1990, so whatever that is now, 28 years ago, that basically said we're killing 3 jumbo jets full of people every other day in healthcare in America because of mistakes that we make. It basically said a lot of these errors result in death. When we are heinous, awful people, how dare we? And that's where we actually looked at the bigger system and said, no, it's not individuals necessarily. It's a systems problem. And that's why you have all these organizations in your institution that look at patient safety. If you want to trickle it down to us in the ER, though, if we're killing all these people nationwide, how much actually happens in the ER? It's not that much, actually. The overall medical error concept, it's about 1 to 2% of medical errors happen in the ER. And I have to tell you, considering the environment we work in, I think that's rockin' great. Now, I would like it to be 0. Our goal for all of us is for it to be 0, but I think that's pretty great. Now, the problem is if you look at them up close, though, if you take those errors and you actually dissect them and look at them up close, the vast majority are diagnostic errors. We make a diagnostic mistake. Okay, we either didn't gather information. There's a lot of reasons it happens. We'll talk about it in a second. The medical legal community considers that negligence. I honestly don't give a flying whatever about the medical legal community. I care a whole lot about doing the best job I can do. So what I'd like to do is break down, how can I figure out where these errors are made, and how can I, as an individual, minimize my part of that process? So to anticipate what these problems are, let's look at the playing field. And the playing field does go to the medical legal literature. Because if you look at closed claims, where actually this lawsuit happened, it either went to court and is done, or it got settled and it's done. So you get closed claims. If you look at the majority of them, what these diagnostic errors are, 2/3 of them are failure to diagnose. You didn't get it right. You failure to diagnose. So you diagnosed the epiglottitis case as pharyngitis. You made an error, a diagnostic error. And why did that happen? Well, it turns out that a lot of those are because you didn't have a deep enough differential diagnosis. That spit thing we talked about this morning keeps you thinking about all the things that might be happening here in this individual patient's clinical scenario. The other thing that we don't do is we don't address things that don't fit. We don't address the abnormal finding. It's like, oh, the heart rate's 105. Well, it's the only thing that's abnormal. It must be okay. When that heart rate of 105 was your clinical clue that, this is a PE, or this is people with hyperthyroidism, or somebody who's doing drugs and not telling you about it. We ignore the finding. So those two big categories. So for you to think about your own practice, remember the differential diagnosis needs to be robust so that you actually know what to look for, know what to think about. And you have to make sure that the things that don't fit, you just don't ignore. You actually look at those and address those. So those are the biggest things that we actually miss. This patient safety culture concept is this idea that none of us goes to work every day and says, I think I'm going to kill a couple people today. I think I've got this on my agenda for today. We don't do that, right? We all go to work with the best of intentions. And it's this, and we all assume personal blame when something goes wrong. We all assume it's got to be something that you did. The reality is it isn't. It's often a systems thing. And when something goes wrong, it's a systems problem. That being said, we have a part in that. And so what we would like to do is, I can't fix the whole system. That's what all of the people in the C-suite are trying to do. I really would like to do the best I can do. So if that's the case, how do I make me better? Well, there's this list of sort of 5 things that you can personally do. One of them you're doing right now. You're getting more knowledge. That top thing on the list you're doing right now. You can do better at your techniques. You can, be smarter. Just be smarter in how you practice. But we're going to focus on here today, for the rest of this talk, is strategies on how to think, with some ideas of knowing where the problems are in how we think. So, there are a couple books out there. One's called Thinking Fast and Slow, which I'm going to talk about in a second, and this one by Jerome Groopman is called How Doctors Think. This is basically clinicians, how we think, and they're both really interesting reads. I recommend them both, and to be honest, I recommend hard copies or paper copies in them both, because each of these books is really cool to pick up and just open and read a little bit of. It gives you all these interesting little bits and pieces of insight. You can read the whole thing cover to cover, that's fine. But if you're not, it's like, it's too dry. It really isn't if you flip through and grab bits and pieces. So this is a fascinating book on how we think, how we process, people in clinical medicine. And the other book is called Thinking Fast and Slow. Now, I'm going to give you a problem here. I want you to think fast. So this is a math problem. Ready? Here we go. The combined price for a pencil and a pad of paper is $1.10. The pad of paper costs $1 more than the pencil. How much does the pencil cost? Answer. Wrong. If you said 10 cents, it's wrong. What you did is you did fast thinking, which is what most of us do. It's like, $1.10 minus $1, it's got to be 10 cents. No, it's $1 more than the pencil. The pencil has to be 5 cents. And the pad has to be $1.05. This is a great example of something that's really simple that makes you understand how we make mistakes not meaning to. And with these kind of jump to conclusion assumptions that we make, sometimes you have to take a step back a minute and say, no, let me think about it a minute. No, actually, it has to be this 5-cent pencil because that's the only thing that makes sense when I really think about it. So this book, Thinking Fast and Slow, it's so interesting. It's so fun to read. Divides the way we think into 2 categories. One is this type 1 or fast thinking, which is what we do most of. For driving to work, you do it. Getting in the shower, you do it. Picking your kids up from school, you do it. Cooking, because what this does is it's based on most of what you do every day. You've had a gazillion times of rehearsal at this. You picked your kids up from school 20 million times. Things that you've just done a bunch of times. It's really efficient. It's a lot of things done fast, except it's prone to error. Just like that mistake you all may have made in that little quick math problem, it's prone to error because you don't do any real processing with this. You do most of your processing in the slow or type 2 thinking, where you actually sit down, you take time, you get to references if you need to, you go to Wikipedia, or you go to UpToDate and look up some things because you're just not exactly sure. You need to really process this. The problem with these kinds of things, again, type 1 thinking is this quick thing and it requires experience. If you do not have an experience in some area, you cannot do type 1 thinking. You don't have any kind of pattern recognition, any kind of mental shortcuts to get you, through something. You actually have to rehearse this, do it again and again and again. That makes you better at this type 1 thinking. Type 2 thinking is awesome and cool and fun. It's lots of analytical approach, but you can't practice this in our job, right? At least not in every case. You would see 2 patients a day if you did this sort of slow thinking. So you can't do that either. The reality is what we really want to do is toggle back and forth. What we would like to do in our job is to go from fast thinking where it's safe and a great place to be, and stop on purpose and slow down and do slow thinking in cases that are more complicated. That's what we would like to do. So good thinkers can toggle back and forth. And actually what Carl Sagan threw in there on top of it is this idea of being mindful, being aware of sort of the environment that you're working in, being aware of lots of pieces of information that you sometimes need, and factoring that into the decisions that you make. So that's what sort of Carl Sagan did with this. So let's talk about the major area. We know we can go learn more stuff, but let's talk about this thinking problem. How do we make thinking errors? And this area is, so what I do with the residents, probably, I don't know, every 3rd shift that I'm on, we do a cognitive error recognition day, where I challenge them at the end of rounds every morning, is to say, or end of every shift, is say, by the end of the shift, I want you to give me 5 instances where a cognitive error was made, either by you, or the patient, or the nurse, or whoever else is taking care of the patient. I want you to pay attention enough that you see how these happen. So what are these cognitive errors? What they, and know, I mentioned it this morning, like the guy with the knee pain who turned out to have gonorrhea today, but thought it was basketball. He made a cognitive error. He assumed, because he'd been playing basketball and his knee was sore, that that's what caused it. He made a thought error. You didn't have to make that thought error because you found the things that didn't fit. He wasn't trying to, patients aren't necessarily trying to fool you, but they're integrating their own bodies and they think, you know, I'm having kidney stone pain, it must be a kidney stone, I've had kidney stones before, but today it's not. Today it's their aneurysm, they're rupturing AAA. So no, the patients sometimes do this too. So it's because we're all human, we can all make cognitive errors. So let me talk through some of the ones that happen in medicine. If I take the same words, I have crushing substernal chest pain, and I say them as a 50-year-old depressed woman, as a cocky Wall Street 30-year-old guy, or as a smelly guy from the street, you are going to interpret those exact same words differently. That's a cognitive error. We do this a lot. This is basically called framing. You take the complaint, you take the words, and you put them in the frame of the patient. And we can do this both directions. So you can basically have different kinds of error. One is called attribution error. So it's a negative stereotype. You've got the person who's there asking for pain meds for their back pain again. It's like, oh yeah, it's just somebody with back pain who wants drugs, but today it's somebody who has a spinal epidural abscess. Yes, it's a drug user. Yes, it's somebody you've seen before, but today it's a spinal epidural abscess. You make the mistake because you said, it's icky person. I'm gonna kind of just not pay as much attention to those words, versus the reason that you don't take care of someone you love. So if you have somebody you really love, somebody you really care about, and they come in and they say, God, I had the worst headache this morning. Came out of the blue, I feel better now. You love that person, so you don't want it to be a subarachnoid. So you're gonna basically, oh, well, it's probably a tension headache. That is an attribution error, okay? That's an affective error. This is basically framing. You're putting the complaint framed in the patient. What you really need to do is take a step back sometimes and say, okay, if I just heard this out in the ether, if I read it in a textbook, what would I think? And then put it back in the frame of the patient. So step away. We make quite a few mistakes based on that. Diagnostic momentum has become a huge problem with electronic health records. So diagnostic momentum is a diagnosis that's stuck on the patient, and now because it's in the electronic health record, it's there forever, that comes with the patient that sometimes isn't right. So think about it. You take care of somebody who's had some pleuritic chest pain, and you don't think it's a PE, so what you do is you write down costochondritis, or even flip it around. It's costochondritis, and you will possible PE. Well, now that PE thing is in the chart forever, and it's stuck to that person, and it may not even be the right diagnosis. So this is called diagnostic momentum, a sticky diagnosis that's not right, that we need to peel off the Velcro and start from scratch. The availability heuristic is basically, you only can tap into what you know. You can only diagnose what you know. So and sometimes it's a busy day, it's probably this, I'm just gonna grab this, it's the most available thing, it's probably what's right, I'm just gonna stop there. That's called the availability heuristic. And that's one of the where our differential diagnosis isn't deep enough. We basically have this availability heuristic where we don't have enough knowledge to get deep enough to find what's really wrong. That's one of the reasons you're here, is you're minimizing your availability heuristic potential error by being here, your cognitive error. The representative heuristic is similar to sort of the affective and attribution orders. You decide ahead of time by looking at someone what you think they are, when they may not be that at all. So this isn't necessarily the words they say. This is, you look like someone who's well-to-do. You look like someone who's asking for drugs. You make an assumption. That's what the representative heuristic is. Anchoring is a big one. So it turns out the two big things that our biggest pitfalls with really making diagnostic mistakes are, one of them is anchoring. And what anchoring is basically you take one piece of information and you just put all your money on that. You wouldn't do it in Vegas. You wouldn't, take whatever, black 16 as your thing you're only going to ever put your money on. That wouldn't work. It just doesn't work. And it doesn't work in medicine either. What you do is as new things come in, you just say, no, I'm sure it's this. Oh yeah, that lab's a lot more, but I'm sure it's this. Oh yeah, their vitals are no, I'm sure it's this. You stick to something. You anchor on that. And the problem with that is that you don't let your anchor get knocked off, if something new comes in. You've got to change that if things change over time. Overconfidence is an interesting one, and you all know somebody like this. You know the person that will, because they want to look good, and because they are super confident, they'll grab some weird-ass thing, and they'll just stick with it as the diagnosis. I had a resident who drove me nuts who had this a while back, where the individual would just grab some crazy diagnosis, and no matter what we found on workup or exam, would just stick with that. I'm sure it's this. I have a hunch that it's this. It's like, no, that doesn't work. So overconfidence bias is basically you decide on incomplete data, and you stick to it. And often you think you're right, and you're absolutely not. Confirmation bias is basically you grab onto only the things that bolster your position and you ignore the other stuff. So rather than anchor on just one thing, what you do is you've got your little anchor, and now you get all the things that confirm it. Oh, it must be that. So look, the heart rate's up a little bit. Oh, look, their temperature's 102. This must be thyroid storm, when, oh no, actually this is somebody with heat stroke. You just basically, you grab only the stuff that supports your diagnosis, and then you leave everything else aside. Search satisfying is basically finding one thing that's abnormal and stopping, which is tempting to do, right? I'm in a busy ER. It's like, my God, the waiting room is bursting at the seams. I've got this person. I'm examining their leg. It looks like cellulitis to me. Cool, I'm done. I think it's cellulitis. When actually it's not, it's a DVT, and you just stop too soon because it's like, okay, I'm gonna anchor on this. I'm gonna grab this, I'm done, I'm busy. It is I'll tell you the big problem, the areas this is a big problem, are in those complicated medical patients. The person who's on 8,000 drugs, has a diagnostic list as long as your arm, and you want to fix that quickly, but you just can't. You have to pay more attention. So search satisfying is basically coming you stop when you get something that's abnormal and you quit, rather than paying attention to what might be the bigger picture. Putting all those things together can come to what's called premature diagnostic closure. It's a person that's kind of unpleasant, and you have one of your biases. And then you also throw in, oh, here's an abnormal finding, cool, I'm done. You throw a bunch of these together, and you come to your conclusion before all the data is in. That's called premature diagnostic closure. All of these things, I want you to think about, next time you go to work, I want you to think about, was you walk around and listen to patients telling stories, or listen to the nurses talking to the patients, or yourself, pay attention to your own self, find several. You will find these in an hour. You're gonna find a dozen of these. They're all over the place. And being aware of them minimizes its impact on your practice. So be aware of this stuff, and it's actually incredibly cool, and you find yourself doing it sometimes. It's like, oh, no. I'm coming to premature closure. Oh, no, I just anchored, shame on me. It's fun. You actually can help yourself be a better practitioner. The other thing to know is those are how you think problems. And inside some of those are biases. Know that you are I don't care how open-minded and I love everyone in the world you are, everyone has biases. And there's a really great website that Harvard has called implicit.harvard.tests, I think. And basically it's a gazillion kinds of tests that you can do online. They don't keep track of you. They just want your data, but they don't care who you are. Where you can actually see, are you biased implicitly against people of color, against gender, against people, different weights of people, whatever. It's really interesting. And it gives you insight into yourself you may not know. Because people don't necessarily, you may think you're not, but these are objective tests that actually tell you if you really are biased or not. So your job is that, I took a bunch of them because I thought, well, I think I'm kind of open-minded, and I try really hard to be open with everyone, but it turns out I had some biases I didn't even know. I didn't even know. And now I'm aware in certain instances of the patients of the type of person that shook out in my bias testing when I took it. Now I know when I go into rooms to take care of them, that's somebody I have to be extra careful. Because these are biases I don't even know. It's not explicit. It's not something like I hate green people. This is something that just happened inside me that I wasn't even aware of. It's really interesting. It's worth a go because it's changed my practice, definitely. So online tests are available, implicit.harvard, as in the Harvard. They're wonderful to do. I highly recommend them. And you may not be what you think you're biased about, you may not be at all. So that's very interesting. Where bias comes into its biggest problem, where bias kind of gets blown out of proportion, are certain sort of conditions. And I want you to look at this list and realize that every single thing on this list is in the emergency department. You couldn't, that is every single thing on that list is what we deal with every single day. So your own implicit biases are going to get blown out of proportion because of what happens with this crazy, crazy situation we work in. It is asking for biases and cognitive errors to get even bigger than they normally are. So if you want to undo it, if you want to factor out this sort of bias thing that we all inherently have, there are certain things you can do, like understanding the sort of biases and understanding the cognitive errors we make, but also doing things like, one of my favorite ones on here is mental simulation. What if it were a 50-year-old woman saying these words to me and not a 17-year-old guy? Would I do something differently? What if the chief complaint were chest pain with shortness of breath instead of being chest pain? Or what if the patient hadn't been referred from their doctor's office with a rule-out DVT paper that came with them, and they just walked into the ER? What would I do differently? If you do those sort of mental exercises, mental simulations, it's a wonderful way to get over biases and over some of the cognitive errors that we make. Okay, I promised you a tool. And I'm going to give you a tool. I teach this to every single medical student that comes through when I work with them. I teach this to all of our residents in their orientation every year. This is actually, it was Bob Weirs came up with this. He's an amazing, amazing academic emergency physician. He's an amazing, amazing guy. And this is basically the 3-step approach to medical decision making. And I love it because what it does is it maximizes fast and it brings in slow when you need it. So this gives you the opportunity to say, nope, I can think fast on this one, and the risk is low, and it also, on purpose, makes you stop and think about the slow ones. So what we're maximizing fast thinking, we're bringing in slow thinking when we need to. And so what you do is you start with your initial H&P. And again, you've already thought about your biases, you already know cognitive errors, patients can do it, nurses can do it, whatever. You get your H&P. You basically now come back, and what you're going to do is you're going to fit it into a system. This is the overall system, but I'm going to break it down for you. So we're going to start first with this left-hand one called straightforward. So you walk out of the room, you've done your H&P, you walk out of the room and the person came in with a chief complaint of ankle sprain, you got a history, did an exam, it was an ankle sprain, you did the examination, it's an ankle sprain. It's not overly swollen, it's not both legs are swollen, it's not super, it's not hot, it's not an irritable joint, it's definitely an ankle sprain. I am sure of that. You get to go right down the fast thinking pathway, done. If you need an x-ray, go ahead and get it. If you don't. And you zip right to dispo. Safely. Okay? Go ahead and do your fast thinking thing. Cool. That's a straightforward case. A complicated case is you get the call from the field. It's a person with 50-year-old guy, crushing substernal chest pain, radiating to his shoulder. He's diaphoretic. He's hypertensive. EKG in the field shows a STEMI. That's pretty straightforward. Okay? It's complicated. He's sick. But as long as you go talk to the patient and their blood pressure's okay, it's not pain tearing through to their back where it's something, ooh, that doesn't fit. No, actually, once you get a chance to talk to the patient and everything still fits, that's another quickie, right? There's nothing that's outlying. Everything is right exactly what I expect it to be. Boom, straight to the cath lab. Done, quick. That's my fast thinking. All good to go. We are all good to go. But take that same person, and when you go talk to them, they're having tearing pain of their back. And it actually started in their upper back, and now it's in their mid back. And you check blood pressures in their arms, and they're different. Whoa, whoa, whoa. Now we got to back up a minute. More often, this is basically, there's an outlier. Something isn't right here. They're having crushing substernal chest pain, and their EKG is stone cold normal. They look like crap. What is happening here? Something's not right. Now you're going to stop. Now you're going to stop and do some thinking. Okay, you're going to actually sit down and do some, you order what tests you think are appropriate, but you're going to sit down and do some thinking. So that's this group. So it's a complicated case with some outliers. And then the group that's the most important to stop and think about are these complex cases. This is the person with 15 medical problems and they're short of breath today, but they have COPD and they have CHF and there's a low-grade fever. It could be a pneumonia, it could be a CHF exacerbation, it could be COPD, I don't know. You're gonna have to sit down and think about it. And that's totally cool to do. If you go rushing ahead, you may do some of those errors we just talked about. So you're gonna on purpose slow yourself down and make some decisions and really think about things. So basically, there's two groups. You're gonna make yourself slow down and stop for a second. It's that complicated case with an outlier or that complex case where there's just too many things that are on the table that you need to think about. So those are the times you're gonna actually stop on purpose. What you're also gonna do though is once you've ordered tests, you're gonna back up any test that you've ordered so that you don't make a mistake by ignoring abnormal findings. Any test that you've ordered, you're gonna look at them all and you're gonna particularly focus on the ones that are abnormal and make sure that you're not missing something. You're not anchoring. You're not overconfidence making a diagnosis. You actually take some time and stop again. If basically that ankle sprain, you got the ankle x-ray, there's nothing funny in there, it's not broken, cool, done. You're the STEMI patient, you get the EKG, it's a STEMI, done, easy. If you get the STEMI patient and it looks like a STEMI patient and the EKG is totally normal, wait a minute, maybe it's not. You're gonna stop again. So you're gonna basically stop when your tests come back. If everything still fits, you're gonna charge ahead. If it doesn't, now you're gonna take more time to think about it. And then ultimately, when you get to the disposition, okay, you get to go home, ankle sprain person, you get to go to the cath lab, STEMI person, you person whose back pain sounded a little weird, okay, I did your workup and now I think you're a dissection. Or you person with a million medical problems, what I think I've filtered into here is that it's a COPD exacerbation. I'm going to admit you. Okay, so I've come to my 4 decisions. What I'm going to do basically now is think it again, and I tend to think of it in this case as if I were on a witness stand in a lawsuit. Am I really right? I'm going to go back one more time and make sure there's nothing that I missed. If I'm really right, cool. And if it's somebody going home, what I want to think about is something brewing here that I need to have them either come back or get a check, or is something brewing here where all I'm getting is like frame 12 of a 200 frame movie? Is this something where I should really anticipate something down the line changing? Because what you may do then is say, you know what, I don't think discharging you is not such a great idea. I think what I'm going to do is put you in OBS, because it might be worth watching you for 12 hours and see what happens here. So, this system sounds clunky. It's not at all. It's super fast. This is a great system to help you make decisions on whether somebody might be sick or not. I think this thing rocks, and I highly recommend trying to integrate it into your practice, especially if you're struggling on how to be fast and you're getting criticized for being too slow, and this helps you. This helps you integrate how to think in sort of patterns that make some sense in the ER. So, remember, our differential diagnosis is often a problem, so remember that spit thing we talked about. We'll do spit again tomorrow. I highly recommend when you're making decisions, if you can, to get out of the chaos. I know of one emergency department that has some noise-canceling headphones that the clinicians get to basically put on when they're thinking, and you're not allowed to interrupt them unless that's really critical, which is awesome. That's pretty great. That's pretty good. The nurses sometimes wear those little vests saying, we're, passing drugs, don't bug me. That minimizes error. So minimize people interrupting you if you can. Please pay attention to the things that don't fit. I can't tell you, it is countless times in my career that it's the non-fit thing that is the answer. It is countless times. So please pay attention to the thing that doesn't fit. And then document things clearly and cleanly. So tricks to consider, and then we're going to wrap. If you can, get your history and physical in as much chunk as you can. Try not to interrupt that, because the next question you're going to ask that was going to give you that outlier thing, now you get interrupted with a phone call. Try to get as much as you can at once, because your linear thinking then stays good. Consider finding this system, and I like this one in particular. If you are pissed off or you are super stressed out, go find your quietest bathroom in the ER, close the door, take off your silly, stupid phone, and do whatever, deep cleansing breaths, dance, whatever you need to do this, whatever. Do something to de-stress, to get that done before you make a big decision, because that's asking for trouble. And then know these medical errors. These are the ones that get us in trouble. Know how these errors work. So you all now know the areas you make mistakes. You understand the idea of fast and slow thinking. You know you're biased. Go test it and see what you are. You know cognitive errors. And I think the system I gave you is very, very helpful. If you find another one, good on you. So I hope that helped. And I think Ghazala's up next. Thank you.